Thank you for joining us. Today we are at the St. Elizabeth Training and Education Center in Northern Kentucky, and we're going to talk about an ankle augmentation procedure to help prevent against chronic ankle sprains. Before I introduce our guests, I'd like to remind viewers you may submit questions on the comments section, and we will be answering those throughout the broadcast. We also have some footage that may be graphic. It's of an actual surgical procedure that I will remind you before that starts, but that's later on in the broadcast too. So at this point, I'd like to introduce our guest. We'll start with Dr. Nicholas Gates. He's with OrthoCincy, and that's OrthoCincy Orthopedics and Sports Medicine. He's also one of the pioneers of this surgery. So at this time, I'd like to introduce Dr. Gates. If you could tell us what you do as an orthopedic surgeon.
Well, thanks, Guy, for having me. I'm an orthopedic surgeon. I've been doing orthopedic surgery for the past 20 years here in Northern Kentucky, including at St. Elizabeth. I'm an orthopedic surgeon who's went on to do some specialty training in foot and ankle surgery. So my practice has been limited to just doing orthopedic surgery and sports medicine for foot and ankle conditions.
Okay. And I also want to introduce Samantha. Samantha is a runner, so obviously you need your feet and ankles to run. So thank you so much for joining us today. And you will hear more on Samantha's story later on. She will tell you what brought her here. But I think for now, let's start with Dr. Gates and you. If you could just describe this procedure.
The procedure we're going to talk about today is a surgery to repair chronically loose ankle ligaments. Patients who sprain their ankle, the definition of an ankle sprain is to stretch and tear one of the main ligaments in your ankle, and frequently there's two ligaments that are torn. Typically that is treated non-surgically, and those ligaments try to heal. The patients the surgery are designed for are those patients who continue to repetitively sprain that same ankle. That ankle becomes loose and unsteady or unstable to them. Many of these patients actually experience pain as well because the unsteady nature of their ankle can make it uncomfortable. We'll talk a little bit about today in athletes. It's a very common problem in athletes. Ankle sprains are the most common injury of all of sports medicine anywhere. And so there's a lot of athletes out there turning their ankles. The patients who become candidates for the surgery have repetitive ankle sprains. And what we do with the surgery is we reconstruct, we repair their original ligament back to the original length and size and strength that it was before. And we also add what's called an internal brace. An internal brace is kind of a somewhat silly or fancy name. And we use that name because it's very common to treat someone with a loose ankle with a brace on their ankle. They wear what you would call an external brace that they wrap around their ankle to try to hold it in place. So when we devised and worked on developing this surgery, the name internal brace came about. The internal brace itself is essentially a very strong way of repairing the normal ligament tissue, and we augment that or add to that this internal brace, which is essentially a very heavy tape of suture. You think of suture as string. This internal brace is more tape-like or a strand, and it's basically multiple sutures woven together to create a tape or strand. We anchor that from bone to bone on top of the ligament that we repaired. So an important concept when we teach this to other surgeons and when we talk to our patients is to make sure people understand this idea, and it's an important thing to understand today. It's not an artificial ligament. It's an augmentation to your own ligament. We don't create a new bionic ligament, but it's an augmentation to take the ligament you have, which has been beat up or torn and stretched, repair that, and then augment or add to it.
Okay, and you mentioned that ankle sprains are among the most common sports-related injury. Could you actually maybe talk about some specific, how do people sprain their ankle?
Wow, just about every way I can imagine, I guess. The typical common is an athlete that comes into the office who sprained their ankle. So many sports obviously include side-to-side motion or activities that include that, but in any athletic endeavor, even straight-ahead sports, we will see ankle sprains. But I also see a tremendous amount. The ankle sprain is not isolated to just athletes. We see a tremendous amount of patients who will turn their ankle stepping off a curb at work. It's an extremely common injury at work. People who do labor-type jobs who are on their feet will sprain their ankle, lifting, turning, stepping up, or stepping down.
Okay, and now that we've talked about ankle sprains, what are some of the common things people could do to kind of help strengthen their ankles?
Well, that's a great question, Guy, and really That's the mainstay of our treatment if I see a patient with an ankle sprain. The mainstay, if someone has an acute ankle sprain, they roll, stretch, and tear ankle ligaments, which can lead to this looseness, the instability we talked about with the surgery, but that's not right where they go. Everyone with an ankle sprain gets treated with typical orthopedic treatment, which they call RICE, which is rest, ice, compression, and elevation, to get their acute symptoms or pain and swelling subside. We use a combination of a large walking boot if it's a severe sprain, or a brace, something to control that, help control that pain and swelling, get the patient back on their feet, and they start doing therapy. Your question is about strength. And this is a great concept I try to explain to my patients, and the therapists that we work with in our department do this as well as our athletic trainers. Our athletes or any other patient needs to strengthen the muscles that control their ankle. A ligament attaches bone to bone. There's no exercise that truly strengthens a ligament. When you exercise your ankle, it's like you exercise any other body part, it strengthens a muscle. So physical therapy to strengthen your ankle after an injury is designed towards strengthening those muscles that will prevent your next ankle sprain. There's a certain muscle when your foot starts to roll or your ankle starts to roll that if it fires and it pulls and it's strong enough, it will minimize or prevent your next ankle sprain. So that is what we do for anyone with an ankle sprain. We try to coax them into therapy, be it on their own, independent, or in our physical therapy department, depending upon their needs and their desires, and we try to get them to strengthen their ankle.
Okay, and why did you choose this particular procedure? I understand you're one of the pioneers.
This came about through my specialty, really. I started doing orthopedic surgery, like I mentioned. I hate to mention it's been quite that long, but about 20 years ago here in the community. And I see a tremendous amount of patients, obviously, with ankle sprains, but those patients, either those same patients I've seen or patients from another physician or another practice come to see me, and their complaint isn't that I sprained my ankle yesterday or last week, it's that I've sprained my ankle 5 times in the past 3 years. Or I sprain my ankle every year. I sprain my ankle every football season, and then I have to struggle with it all season. And it gets better in the off season, and I start spraining it again. Or people who work for a living, and they're out there spraining their ankle, and it's sore. So those patients start coming to me. In my training, before I started practice, we have a good procedure where we would repair and reconstruct those ligaments. The same ligaments I mentioned to you earlier, we would do a surgery, go in and reconstruct the tissue that the patient has, and we had ways of anchoring that ligament into the bone to strengthen it. What all surgeons who do what I do, and ankle specialists like myself, would sometimes be frustrated with is that tissue wasn't always the greatest. It had been stretched, especially if it's been sprained 6, 7, 8 times or sprained over the years. By the time I get in there to try to repair that ligament, it's kind of thinned out. It's not in the greatest of condition, and that was what we had left. So we would typically augment that by reaching for another small section of tissue in your ankle that really didn't belong there. It didn't belong up on your ankle ligament, but we would steal it. It was a tissue we could steal, and we would augment it. It was actually called an augmentation procedure because we wanted to tighten that up. But we were still worried about it, so we put you in a cast. What got us working on this innovation is that frustration that we're fixing this, putting a patient like Samantha here in a cast, making them wear a cast for 6 weeks. Things would stiffen up, but we wanted that to heal real tight. We were afraid to move it. We didn't want to let that ligament move. And in orthopedics, motion is life. We want to fix things to get things moving and working again. So that kind of aggravated me and aggravated others. So especially when you start looking around other areas of orthopedics, the knee, for example, someone tears an ACL ligament in their knee. Truthfully, this might come as a surprise to many who've heard about ACL injuries in the knee. In the past, people would have an ACL ligament repaired, and they'd put them in a cast. And they'd put their knee in a cast, hold it still because they're afraid that wasn't going to hold. Now that doesn't happen anymore. Patients who have an ACL reconstruction now, they get their ACL reconstructed, they get a soft dressing, and they get their knee moving right away. So us ankle surgeons like myself, we were jealous. We're looking at our knee surgeons and our knee patients getting their ligament fixed and running off to therapy and moving their knee, and here we are fixing the ligaments, putting them in a cast and telling them to sit still for 6 weeks. So that was the impetus, the idea. So a gentleman who's actually truly the original designer of this procedure is from Scotland, sports medicine surgeon in Scotland who really was interested in this idea. And so we started working on that 5 or 6 years ago to figure out a way that we wouldn't have to put that cast on anymore. So that's really what drove me and drove some of my colleagues to help work on this, to get it to the point where we could start to rehabilitate that patient early.
Well, we do have a question from a viewer.
Sure.
This is from Tina. Does this procedure just help people who've had recent issues as well as people whose issues may have started 20 years ago?
It is surprising that I don't know about 20 years, but probably. I see patients who will come into my office in various ways, and they sprain their ankle, and a brief conversation leads me to find out they sprain their ankle frequently going back 5, 10, 15, even 20 years. There are people, many people, living in this world with a loose ankle. And where that comes from, I think, is the non-surgical treatment of ankle sprains, which is appropriate and good, but your knee or your shoulder surgeon that you see is appropriately going to treat your ankle sprain with a brace and some therapy, and you're going to get better, and it's going to feel okay, and you're going to go on your way. And that becomes a repetitive issue that doesn't kind of rise to the top. So the short answer is absolutely, I see patients who have ankle instability for many, many years. One of the downsides to that is that there's pretty good evidence that the more times you turn or sprain your ankle, you might be damaging the cartilage each time you do it. And so the longer it's been and the more times you do it, that's probably not good for that soft cartilage in your ankle. And so I see people with ankle arthritis, and I'm talking to them about treating their ankle arthritis, which is a totally different thing that we have treatment for. But in their history and their story, I find out it started back in high school when they used to sprain their ankle all the time. So absolutely, there are people living long lives with loose ankles.
Okay, and then from a surgeon's perspective, does this augmentation replace any other type of surgery?
This augmentation is an evolution of reconstructing lateral ankle ligaments, an innovation in technique more than it is a total replacement of a previous procedure. I do the procedure very similar to how I always did it, with the addition of this internal brace. Remember I mentioned to you I used to reach down for that other tissue to make it stronger. I don't have to do that anymore. So now my procedure is completely anatomic. I've fixed the ligament where it originally was. I put my augmentation internal brace on top of that. I don't have to reach for anything else. So when we're done in the operating room, everything is as it was at the beginning. So that has changed that little bit of augmentation. What it has really replaced is some historical techniques where we used to not only steal a little tissue, we used to steal a lot of tissue. We would go in your ankle and steal a different tendon because your ligament was so bad, we would have to take one of the tendons, put it inside your ankle to rebuild that ligament. It's kind of a rob Peter to pay Paul mentality. And that's okay, and it had its role and it had its successes, but boy, that wasn't the greatest thing because that was a tendon you kind of was supposed to do something, right? And now it's gone, I had to use it for your ligament. So this procedure has greatly lessened the need for these other major reconstructive ideas where we would steal your tendon. That part it has replaced.
You partially answered my next question too, and I was just going to flip it and say from a patient's perspective, how does this procedure benefit them?
That's probably the biggest driver of this. The biggest driver of this is the patient's perspective. And patients who are having this now, they don't know this other perspective, but when I started practice, I would do this ligament reconstruction, and they would go into that cast for 6 weeks and sit. And they would stay on crutches for 4 or 5 weeks and a cast for 6 weeks. And then we'd say, all right, now let's start rehabbing your ankle. Well, they already had the pain and swelling from their chronic ankle sprains, some pain and swelling from their surgery, and then they sat in a cast for 6 weeks, getting weaker muscles, stiffer tissue, but we had to do that so it would heal strong enough. And so the patient's perspective now is totally different. We do this surgery, we put them in a splint for a few days just to feel comfortable, and within 3 or 4 days, they're in our physical therapy department, putting weight on their foot, walking off the crutches, and our therapists are starting to cajole them and encourage them and try to feed them confidence. Let's get your ankle movement. I even start that before the surgery. I want them to know that the great thing about this, and the reason we do it for them, is that when I walk out of the operating room, I know I'm going to like what I got. I know it's going to feel strong. So I want to motivate the patient to go work hard on their therapy, because I can fix that ligament, but I can't make that muscle stronger still. The same therapy we talked about earlier in this conversation about you have muscles that help control your ankle. That's the patient's job. So my job is to fix the ligament, and then I really love to try to motivate the patients now, especially the young athletes or athletes of any age, because they want to get back. They're hungry to go back and do what they do. I really try to motivate them, and I put it on them. I love that. I get to put on them. They say, well, when can I go play soccer? When can I go play football? When can I go running? And I say, well, gosh, I'm happy to have you do that in 8, 10, 12, 14 weeks, depending upon what sport or what it is. I said, but I'm going to talk to you about that when you come in here on your next visit and show me how strong your calf muscle is, show me how well you've done your therapy, and show me how you've done those things. So they don't have total control over it. There's little bits and pieces of it that they can't completely control, but we love to get that, and that's the patient perspective. They now own it, and they're going to go and work on their therapy. Day-to-day life, it's just easier to get back to work, it's easier to get back to school, it's easier to get back into your day-to-day life within the first week. Return to sport, it's getting motivated to do that. So that's been a lot of fun.
We have another question. This one is from Brad. If I was prescribed to wear an ankle brace or wear an ankle brace to support my ankle from past sprains, will this procedure allow me to stop?
Maybe stop using that brace?
The ankle brace, correct.
Yeah, that's a great question, and it's one of my favorite stories. I just recently came back from another trip where had the great opportunity and the honor to teach other ankle surgeons who were just graduating from their specialty training, and this particular procedure was one of the things we were teaching. And so we tell great stories, and it works with my colleagues, but I did a soccer player who was a college soccer player, and he had aspirations of moving higher to that into professional soccer world. And I did his surgery maybe a year and a half ago, and I'm in the office the other day, and I'm looking through my charts, or my charts, we don't have charts, but my list of patients on my electronic medical record, and I see his name on there, and I kind of flipped through it, I'm trying to remember, I kind of remembered his name. It's like, oh boy, and when you see that as a surgeon, you see this name on your list, like, oh gosh, something must have happened. You know, he was already long gone and back to playing soccer, and I was like, oh, something, maybe twisted his ankle again, or hopefully he didn't re-injure that ankle, maybe it's his other ankle. And I went in to see him, and that was his question. And the reason he was there, I was like, well, you have any trouble? And he was there with his athletic trainer from his college. And he's like, no, it's great. I'm like, well, I'm like, well, why are you here if it's great? He needed a note from his minor league soccer team he was going to go play for. He didn't want to wear a brace anymore, and they knew he had had an ankle surgery, and they said, well, you have to wear a brace unless you get a note from your doctor that says you don't have to wear a brace anymore. I said, well, how's your ankle doing? He says, it's great. I go, do you like to wear the brace? He goes, no, I hate it. It rubs. I feel better without it. I feel stronger without it. And especially soccer cleats these days are very small. Soccer players love to feel the ball in their foot. So they don't like stuff with that brace inside their soccer cleat. So he wanted a note from me saying he didn't have to wear the brace anymore. I said, absolutely, I'll give you that note. His ankle felt great. I could examine him there. So absolutely, that is part of this process. We want to fix your ligament so you go out back to your life, not back to your brace.
All right.
Yeah.
We have another question for you. This one's from Nathan. If I crack my ankle, does that hurt my ankle long term? What are some tips for general ankle health?
If I crack my ankle.
Crack the ankle.
Wow.
I guess like cracking a
I'm going to
finger.
assume, and probably like popping
Right.
some people pop their joints in their finger. That's probably what's on. There are patients who will have a cracking sensation, and this goes in other parts of orthopedics, but particularly in the foot and the ankle, where if they rotate their ankle a certain way or the other, they will feel a popping or cracking sensation. I will tell that person, as long as there's no other issues going on with pain or other problems, that's probably benign or not dangerous. It's most commonly caused truly not by the ligament issue we're talking about, but some tendons that roll around your ankle, and depending upon how skinny or heavy or the shape of your ankle, you might, and if you're more flexible, you might be able to create a certain cracking or popping sensation with your own motion in your ankle that is not considered necessarily abnormal. I think he also mentioned about general health.
Correct.
General health would be Achilles tendon stretching, and if you're an athlete, it is your athletic trainer, or just some basic, what we call proprioception, which is a fancy word for control. Achilles tendon stretching for range of motion, and some basic, what I'll call boring, ankle strengthening and control exercises. We've instituted this in a lot of our high schools in our sports medicine program. A quick story, a lot of our football players want their ankles taped. There is a preventative method to prevent, so they don't keep spraining their ankle. And so our poor athletic trainers are in the training room, and Samantha could probably attest to this over at Thomas More, the other colleges, is that you got all these athletes lining up, and the athletic trainer's busy as can be and taping all these ankles before every practice and every football game. So we've kind of turned that on them. So we have a ankle sprain prevention program, particularly for athletes who've sprained before or had a little bit of trouble, is we teach them the exercises to do, that they can do them pretty independently, the strengthening exercises to do, And she made a rule: you don't get your ankle taped unless you come to my ankle sprain prevention rehab course, and then I'll do it for you. And it's dramatically, and so I think one of it was that a lot of people just wanted their ankles taped because it looked cool, and they had colorful tape and everything like that, so she was able to cut her workload down there a little bit, but also because it got those athletes involved in doing those exercises, which really, quite frankly, could decrease the chance of their ankle sprain more important than the tape.
Okay, we have another question. This is a running related question. This is from Heather. Is this augmentation a solution for plantar fasciitis?
Heather, unfortunately, it is not. I wish that it was, and if I had another innovation to cure your plantar fasciitis, I would do it today. Plantar fasciitis is a struggle for many, many patients, including runners. But no, this innovation is specifically for people with loose ankles and chronic ankle sprains. There are other innovations out there for plantar fasciitis treatment, but that's a struggle of a diagnosis at times.
Fair enough. And at this time, I think if you recall, we mentioned that we would have some actual footage to view. I do want to remind viewers that it is a little bit chronic. It's of an actual procedure. So I just want to ask you, Dr. Gates, narrate while this footage is showing just what actually happens during your surgery. And this will go on for about a minute and a half.
All right, well, I'll do my best. In full disclosure, I don't have exact view of what you may be looking at out there on your computer, but I'll do my best. The procedure you'll see on the video, if you're so inclined, and it's a close-up, so you see the surgery, so I don't think it's too terribly graphic, but I guess that's my perception. Is you'll see a surgery where we go down, we find the original ligament, and I think by the time you get on this video, we've already found the original ligament, and we have sectioned that loose ligament that is kind of overstretched. Frequently it's still there, it's not gone, but it's kind of loose, it's floppy, it's overstretched. So I'm going to section that down the middle, and I'm going to bring that back tighter, and I'm going to anchor one end as I tighten it up against bone with kind of a standard little, what we call suture anchor, which is a little device that fits in the bone, and I can suture that ligament up. That's what we've always done. We still do that. I always did that, but that's all we had. Sometimes that tissue was good, sometimes it wasn't so good. But what you'll see on the video is I do that, and then we're also going to place, with a little bit larger drill and a little bit larger tap that you see on the video, this actual internal brace. That's going to lay on top of the native or the original ligament that we just repaired. So on the video, you'll see a little drill and a little tap creating little holes in the bone. Those go in very, very specific spots. That's one of the things we do with the training, is making sure that the surgeons are getting this right where it belongs, because we're putting it right where that ligament originally lives so that it functions like that ligament, lets your ankle move like that ligament does. So it doesn't come through great in the video, but there's very special care to putting those holes exactly where they belong. And then you'll see this internal brace being implanted into each of those bones with a little thing we call a swivel lock, which is an absorbable screw, if you will, that gets buried completely into the bone, and it goes into that drill hole along with the tape, and it's called an interference fit. So if I have a hole and I put this tape in there, I put this swivel lock in there, it can't pull back out because it goes in nice and snug, and it squeezes and holds it in. Now what's going to happen after that's in there, we have what we call zero-time strength. We have great biomechanical studies, and a colleague of mine, Dr. Clanton, did this out in his lab out in Colorado. Zero-time strength, that is twice as strong as your native ligament. So I know that when I walk out of there, that I can let this patient walk on it, I can let them move it, and that ligament's not going to stretch or tear, because right now I have that strength. So that internal brace is doing a really, really important job those first 6, 8, 10 weeks. But what's also happening during that time, we're moving your ankle, we're rehabbing your ankle, the ligament itself is healing. So in the end, the ligament's doing the work. So what you see on the video is that internal brace laying on top of tissue that's the actual native or original ligament. And that's going to start doing a really, really important job for those first 3 months. After that, you kind of live on your own ligament. And the internal brace, I always say, is just kind of along for the ride. It's not dissimilar if I fix your broken ankle and I put a metal plate on your broken ankle to hold the pieces of bone together. Those first 6 or 8 weeks, that metal implant or plate or whatever I put in, that screw, is really, really important. But once the bone heals, the bone's doing the work again, and the screws are just along for the ride. So the internal brace is similar to that, is that we're going to get that ligament to heal in its right spot, its right strength. We're not going to let it stretch out, but it won't stretch out even though we let you move it and rehab early. And then the internal brace just kind of sits there, and it's along for the ride.
Okay, and Dr. Gates, approximately how large is the incision?
I think I'd say 2.5 centimeters, maybe 3, depending upon the patient. It's not a large incision. We do an ankle arthroscopy with each and every case. We didn't talk about that earlier, where you get a small poke hole. We do arthroscopic surgery of the ankle, just like we can do in the knee and the shoulder. That's typically to look on the inside of that ligament, clean out scar tissue from previous sprains. Sometimes there's cartilage chips or defects in the cartilage we have to treat simultaneously. So you get little poke holes for the arthroscopy and about a 2.5 centimeter incision maybe, where we actually insert the ligament. And as time has passed, as we've perfected that technique, that incision gets relatively small, even smaller.
All right. And you did a fantastic job describing the surgery. Approximately how long does that take?
With the ankle arthroscopy and putting the ligament in, typically 25 minutes, maybe 30 minutes, depending upon the case. Sometimes it takes a little longer if there's more pathology inside the ankle that we're treating with your arthroscopy, but a straightforward typically is no more than 30 minutes.
Okay, so now someone has had this procedure. Can you talk post-surgery now? What actually happens next?
What's happening now is the patient has the procedure, goes home that same day. We do lots of Novocaine. We have a pain management protocol that we really have worked hard on that include Novocaine blocks that linger and keep it numb, the incision numb, so you're not having much pain, decreased use of pain medicine. We let patients put partial weight on their foot immediately. We do send them home with advice to be lazy for 3 days, prop it up and put some ice on it to feel better, get that initial swelling from the little incision to settle down. And then they're in our office or typically right in the physical therapist's office within 3 to 5 days. And that visit, the dressing comes off, walking boot goes on, we seal their crutches, we encourage them to get full weight bearing, and they start their exercises that day.
Okay, I was going to ask what happens with range of motion, and then how long it takes somebody to get back up to walking again.
My goal is that they're back up to walking within 3 to 5 days without crutches after that first visit. Now, it depends on the patient. Some people are a little bit more anxious than others. It's not harmful if they're going to stay on their crutches for a few more days, but we really let them be full weight bearing without crutches within 3 to 5 days. And many patients, they're a little hesitant, and they do it and says, hey, that feels pretty good, and I don't want to drag these crutches around anymore, so they ditch the crutches. So as far as getting back to your daily life, it's within the week.
All right. And can you describe who is an ideal candidate? Who should have this procedure?
The ideal candidate for this is anyone who is tired of either I repeatedly sprain my ankle and I feel pretty good in between sprains, it doesn't bother me that much, but then I go do something and it sprains again. And that includes the athlete who sprains it a couple times a season and lives in the training room getting therapy and trying to wear their brace, and then does the same thing in the off season and it all starts the next season. That includes someone who works for a living and they're out doing their job, they're on their feet and their ankle wants to buckle and give on them at their job. That includes, and that's kind of the typical most ideal candidate is my ankle is not bad except for the stupid thing keeps rolling all the time. It just gives out. And that the second subset of patients that really has benefited from this, and I think that gets missed more often, are the patients who say my ankle kind of hurts all the time. And I would tell you at the beginning of my practice, we probably weren't recognizing those patients as much. I talked to those patients more. It turns out a lot of those people are suffering micromotion or instability episodes where their ankle is shifting in their socket a little bit in their day-to-day life, going up and down steps. They might do something strenuous at work and it gets aggravated. And a lot of those people with aggravating chronic pain in their ankle that's not terribly severe but is annoying, turns out they've had ankle instability all along. So those are probably the two patient populations. I'm seeing patients who just flat out know. They walk right in and they say, my ankle's, they use the word, my ankle's unstable. It gives out all the time. Tired sprain. The other people just, my ankle kind of hurts. I'm not sure what's wrong with it.
Okay, what's the difference if someone wanted to try to go to the store and pick up a brace themselves versus coming in and seeing you?
Fit and finish, maybe. It's certainly, boy, I tell people this all the time, healthcare is expensive and there's probably not anything I can figure out a way to do that's not. So yeah, people are always looking for ways to keep that less expensive, and we do that in our office every day. We try to do that for folks. You can go get your own ankle brace, and there's some stuff, and I keep an eye out on this stuff at various stores and retail, and I see where they sell them. And so I try to keep myself aware of what's out there. The problem is they're typically not of great quality because they're mass produced and they sell for a lower price, and there's typically a reason for that. But there's a lot of instances where we use those, and you can use those effectively. There's nothing wrong with doing that as a first line of defense, or if your ankle's a little sore.
Okay. And Dr. Gates, promised that I'd bring in Samantha. So
Sure.
I think at this point, I'd like to hear from Samantha
Great.
now. So I guess first thing, Samantha, What made you take the leap and have this procedure done? What was going on with you that brought you in?
Well, I've had a chronic ankle instability all my life. When I had this procedure, I had just graduated from high school, and in high school I was a track and field athlete during the spring, and then I did ballet and gymnastics in the off season. So I was always putting wear and tear on my ankle, and I suffered, I'd say, 13 to 15 ankle sprains throughout my athletic career already.
And then what made you decide to use Dr. Gates in St. Elizabeth?
I really liked when I went in to talk to him about the ankle issues I was struggling with. How much he talked about how we could get me back to recovery quicker and I could get back into athletics. He seemed to really understand the athletic mindset and how I wanted to get back to playing sports and how this surgery would help me, because at that point I was hoping to begin my college athletic career, and with the ankle issues I was having, I wasn't sure I would be able to, but this surgery gave me a chance to pursue that opportunity.
Yeah, as a runner, I can imagine you definitely need your ankles.
Yeah.
Yeah. And then how are you feeling now?
My ankle has been great. I mean, I had my surgery almost 2 years ago, and I have not sprained my ankle since, which is kind of miraculous for me, because before the surgery I tended to sprain it almost, I'd say, every 3 months or so, and it's been doing so much better.
So does it actually help your performance?
It has, actually, because, well, it's a lot easier to perform well on the track when I'm not spraining my ankle every 3 months of the season and getting set back, having to tape it up, trying to fit a brace inside a track spike. That doesn't work so well, but my performance has done so much better.
Okay, and we've talked about the procedure and what happens afterwards. Could you just describe with yourself what happened with you in your recovery, what that was like?
My recovery, when I first did it, my procedure was about 2 years ago, so I was in a cast for about 2 weeks, and that was the hardest part for me, just because I had to sit still, and as a runner I don't like to sit still very much, but I was in physical therapy within 2 weeks, and that actually, it was not as hard as I thought it would be. I was a little scared at first going into it, but like Dr. Gates said earlier, they give the power of the physical therapy to the patient, so you can get back to running, basically within 8, 10, 12 weeks, just depending on how hard you work in PT, and that was a great process for me, because I would go to physical therapy, I think, 2 to 3 times a week, and they would push me really hard to work on my range of motion and my strengthening, and I could feel myself getting stronger much faster than I anticipated.
So as a runner, what was that like to hear you had to be off for 8 weeks?
That was a little disheartening, especially because I was trying to prepare for my first college season, and it was a little scary to be told, okay, you need to have surgery and sit out for a little while, but I knew this surgery would help me get to where I wanted to be.
Okay, and overall, how were you treated by Dr. Gates and St. Elizabeth?
They were great. Dr. Gates made the surgery seem very approachable and a lot less scary, because no athlete wants to hear the word surgery. I mean, it's kind of, we try to ignore it. We just want to, ice and bandage and not do anything about it. But he made the surgery very approachable, and then the staff, his surgical staff and then the physical therapy staff were amazing.
Okay, and just one final question. What piece of advice would you give to someone who's considering this surgery? What would you tell them if you could?
Probably just not to be scared of having a surgery. I mean, it is scary, like I said, especially for athletes, and just going into that feels like this huge decision, but it's not as scary as it sounds, and the recovery process it's hard, but it's worth it.
Okay. Well, Dr. Gates, let's bring you back into the conversation. And I just have a couple of just closing questions. So how important was it for you to bring this surgery to OrthoSensei Orthopedics and Sports Medicine and the benefits?
Well, let me start with making sure all the track athletes know out there as well. I'd love to hear Smith talk about our ankle doesn't sprain anymore. I do not want to tell anyone I can make them run faster. I'll make sure that that's quite clear, as much as we would love to do that. Hopefully you can train better and run faster if your ankle's not spraining, but we certainly don't have any speed inside the internal brace just yet. We'll work on that later. So,
fair enough.
but the reason we wanted to bring it is, like I mentioned before, is that there's stuff we do in our practice that I love, and that I think it works great, and I have solutions for people, and we take care of people, and they get better, and we know that that's going to work, and it has a great timeline. There's other patients I see, unfortunately, have extremely complex ankle problems, and in our world we call that salvage. We want to make their lives as best as we can, knowing that I cannot take this terribly complex problem and make it normal. This chronic ankle instability problem fell in the middle of that, and that we liked what we were doing, but there was always this nagging thing that it could be done better. As we looked around, and I challenged the folks that we worked with on the development of this, we always challenge each other. It's like, don't solve a problem I don't have. This stuff over here is working great. Let's work on this problem. We can't get them rehabbed fast enough. Some of them are rehabbing early and then stretching out. It's not holding in the long term. So what can we work on that? So it was really a very clear-cut problem that we saw great potential with. And that was the great thing about bringing it along. I started in early with a couple of other surgeons. At that point, we didn't have the specific kits, the specific instruments. We were using instruments that guys were using for various shoulder procedures and other procedures, and putting that together to get the right stuff. We worked with some engineers on fine-tuning that. I did some lab work at a biomechanical lab in Florida where we tested certain ways of doing it to make sure we were doing it the best way, the easiest way, the most reproducible and strongest. And I really appreciate St. Elizabeth's help in it to kind of let us do that legwork initially, get it to the point where it was ready for prime time, if you will, and then bring it to the community here in Northern Kentucky and Greater Cincinnati overall. So it's been a pleasure for me. It really reinvigorated, a lot of excitement I had in the sports medicine world. So it's really been quite a ride.
Okay, and last question, as one of the pioneers of this procedure, do you see it as a game changer?
Oh, it has been a true game changer. I think I mentioned earlier, I just came back from a course that I typically teach each year, and we're teaching what are the graduating foot and ankle surgery fellows from around the country. There's roughly 78 or 79 orthopedic surgeons who finish their orthopedic surgery training, and they do an extra year of training for specialty ankle procedures. We had about 2/3 of all of them in one place last week, teaching this and other types of ankle procedures. It's a 2 or 3 day long educational event, and I've been doing that for the last several years. We started doing this. We polled that audience, say how many people have seen the internal brace and done this procedure in their practice with their own mentors, and from wherever city they are from the country. And 3 or 4 years ago, you'd get 1 or 2 hands up. Yeah, my mentor's thinking about it. He's looking at it. He's not sure. And this past course we had, just about every one of them has already been exposed to it, at least exposed to it, if not already using it in their daily practice. It's been a game changer for the sports medicine, the ankle instability world. And really, it's a solution. I love to give that to my partners who are team docs out there for our high schools and our colleges, that they don't have to, we don't have to keep going on to the next ankle sprain and the next ankle sprain, and the athletic trainers, they don't have to keep going on to the next ankle sprain, the next one. That we have a pretty good solution for that now.
Okay, well, I want to thank you both for being here. As a weekend runner, I was fascinated by all the information that you shared with us, both of you. So I want to thank Dr. Gates, you for taking time out of your schedule to be with us today. Samantha, I want to thank you as well for being here. And then I'd like to remind viewers, you can still submit questions on the comments section, and we will get to those throughout the day. And if you do have any questions regarding your ankles, please see your physician, and we want to thank you for joining us as well.